In this section, we will be talking about ventricular rhythms. Ventricular rhythms are the most dangerous rhythms. If you recall, our discussions have all been focused on supraventricular rhythms, meaning impulses that originate from above the ventricles or above the bundle branches. These include your sinus, your atrial, and your junctional rhythms, which we cover. Comparing supraventricular rhythms to ventricular rhythms, the differences are going to be as follows. Supraventricular rhythms follows the normal conduction pathway, so therefore it causes a normal P wave and a normal QRS complex. However, when impulses originate from the ventricles, then it's going to be manifested by an abnormality in the QRS complex. Such abnormality will be reflected as a wide QRS complex. We are going to discuss the various ventricular arrhythmias and their interventions. Whenever impulses originate from the ventricles, they will have a very distinct characteristic. And so we'll learn about those characteristics at this time. Impulses originate from the sinus node. They go into the atria and proceed to the AV node, and then the bundle of His, and onto the bundle branches, and to the Purkinje fibers. This results in a normal P wave as well as a normal QRS complex. When beats originate from the ventricles, they're no longer going to be conducted the same way that we had just discussed. Let's take a look at how electrical impulses are going to travel through the ventricles. So let's say an ectopic focus in the ventricles, right here, initiates an electrical impulse. The electricity will have to travel through muscle mass in order to depolarize the rest of the ventricles. And because they are not going to be moving about through the normal cardiac conduction system, namely the bundle of branches, what's going to happen is that the movement of electricity will be through muscles, and movement of electricity through muscle mass is going to be a little bit more delayed than it would be if it is going to go through the normal circuit. Thus, you will have a wide QRS complex as a result of the ectopic beat. As illustrated here, the characteristics of ventricular beats are the following. 1. You have a wide QRS complex. 2. There's no relationship of that QRS complex to a P wave, or it does not have any P wave at all. And number 3, the T wave and ST are opposite the direction to the QRS complex, and this phenomenon is described as PAR-DT. Premature ventricular contraction is an ectopic beat originating from the ventricles. It carries the characteristic of a ventricular beat as we discussed earlier. For it to be a premature ventricular contraction, it must have the following characteristics. 1. The QRS complex must be early. And 2. This early beat is wide. And 3. That the wide QRS complex is accompanied by PAR-DT, meaning to say that the QRS direction is opposite to direction of the T wave. And lastly, there is no relationship to a P wave at all. Premature ventricular contractions by themselves are manifestations of an irritable focus in the ventricle, and therefore it can be a significant finding. However, occasional PVCs are not going to be dangerous. PVCs have the following characteristics. 1. The rate depends on the underlying rhythm. The rhythm is going to be irregular as a result of the premature beat. The P wave, there will be no P waves associated with the PVC. The PR interval, none associated with the PVC because there's going to be no P waves. And the QRS complex for that beat is going to be wide, meaning to say that it is going to be more than 0.12 seconds or more. When describing PVCs, it's important to be as complete as possible. And we can classify PVCs and describe them according to their morphology or their characteristics. So one of those particular classifications of PVCs is going to be a unifocal PVC, meaning to say that all the PVCs look alike. All the PVCs are the same, which means to say that they're coming from the same focus in ventricles. cells, causing this uniform characteristic or morphology of the PVCs. However, when ventricular beats originate from multiple sites, the difference in the foci will also result in differences in the characteristics of the PVCs. So focus your attention to the lower part of the screen and you will notice that there are PVCs, and these PVCs are of different kinds. And this is what we term multifocal PVCs. PVCs could also be described if they occur in a pattern. So if it occurs every other beat, so there's a normal beat, a PVC, a normal beat, a PVC, a normal beat, and a PVC, then that pattern is what's called a bigeminal pattern. It is also referred to as ventricular bigeminy. The ECG strip on top illustrates ventricular bigeminy. It also happens to be a multifocal ventricular bigeminy because the PVCs don't look alike. PVCs occurring every third beat is known as a trigeminy. And in the example that we have a unifocal ventricular trigeminy. The PVCs could also occur every fourth beat, and every fourth beat is described as a quadrigeminy. And in this particular example, we have a multifocal quadrigeminy. So the question is, which one is more serious? Is it bigeminy, trigeminy, or quadrigeminy? You probably have already realized that ventricular bigeminy will occur more frequently, and therefore this is going to be much more serious than ventricular quadrigeminy. PVCs, in addition to occurring in a specific pattern, could also be described as couplets or paired PVCs. As you notice, in this particular example, we have two sequential or successive PVCs. And two successive PVCs is what is called a couplet or a paired PVC. Additional PVC terminologies include triplet. And in triplet, it means to say that there is going to be three successive PVCs in a row. And lastly, PVCs could also be described according to its occurrence in relationship to the T wave. If you recall, the T wave is a vulnerable period. Over where it is identified by an arrow is what we call a very vulnerable period of time. An ectopic beat occurring at any time during this time of the cardiac cycle is going to precipitate a dangerous arrhythmia, in particular ventricular fibrillation or ventricular tachycardia. So a PVC could also be described according to its proximity to the vulnerable period of the T wave, known as the commotio cordis risquinda. Notice that there are two PVCs, PVC mark A and a PVC mark B. Mark A is a very, very dangerous PVC. And the reason for that is it occurs right very close to the T wave. And this is what is known as an R on T phenomenon. PVC mark B is far away from the T wave, and therefore is a benign PVC in comparison to PVC-A. So in addition to our descriptions of PVCs being unifocal or multifocal or perhaps bigeminy, trigeminy, quadrigeminy, we also would like to make sure that we describe the PVCs in relationship to their occurrence relative to the T wave. The closer they are to the T wave, the more dangerous they become because they could precipitate a dangerous rhythm, namely ventricular tachycardia and ventricular fibrillation. There are many causes of PVCs. They could be a normal finding, but they could also occur as a result of myocardial ischemia, myocardial infarction, congestive heart failure, hypoxia, hypertension, mitral valve disease, particularly in mitral valve prolapse, or perhaps stress, including the intake of stimulants such as caffeine or nicotine or others. Electrolyte abnormalities, in particular those that are participants of the cardiac cycle, namely sodium, potassium, magnesium, are going to be causes of PVCs if they become abnormal. Sometimes during reperfusion following a PTCA or following a administration of a thrombolytic agent to manage myocardial infarction, PVCs might occur as a manifestation of the reperfusion that occurs in the cardiac muscle. Procedures that directly irritate the heart, such as in cardiac catheterization or in pacemaker insertion, may also be causes of PVCs. Infrequent PVCs do not require any treatment, but significant PVCs should be treated. And when we say significant, what does that really mean? Well, if PVCs are in the presence of an acute myocardial infarction or after a cardiac surgery, then this becomes much more worrisome. The frequency of the PVCs, the more frequent the PVCs are, the more worried we should become, and therefore they should be treated. And generally, more than 6 PVCs per minute, particularly in the setting of an acute MI or cardiac symptoms, is going to require treatment. The characteristics of the PVCs also will determine whether a treatment will be necessary, such as when they're multifocal, when they're paired, when the PVCs occurs right on the T wave, known as R on T, or whenever there are runs of PVCs, runs of 3 or more PVCs, then the physician should be alerted so that proper management of these PVCs could be undertaken. The treatment of PVCs depends on the cause, but they generally would include antiarrhythmic agents such as amiodarone, lidocaine, or procainamide. Low-dose beta blocker is actually the first line of drug that is used for the management of PVCs. Let's take an example of a ECG demonstrating PVCs. The rhythm is irregular because of the presence of premature beats. And so this is a premature beat. Again, it's repeated over here. And there are 2 premature beats, and they are wide. They are having the party T characteristic. The direction of the QRS is going up. The T wave and the ST segment is going down. So I know that this is a premature ventricular contraction. The rate is that of the underlying rhythm. There is no P wave associated with these PVCs at all. And the PR interval for the normal rhythms or the sinus rhythms are normal, and the QRS also are normal. The interpretation for this ECG strip is we have a sinus rhythm with unifocal PVCs because they all look alike, and a couplet because there are 2 PVCs right over here that are sequential or one after another, and they look the same. So the interpretation is sinus rhythm with unifocal PVCs with 1 episode of ventricular pairing. It's occurring regularly, and this is a beat that is early, and therefore it's premature. The premature beat is characterized by a wide QRS complex. Let's measure this QRS complex. It's very wide, okay? So it is this wide, and it's around 6 boxes. So that would be around 0.24 for the QRS complex. Very wide. And the direction of the T wave is opposite the direction of the QRS complex. This is a ventricular beat, and because it's premature, I'd call this a premature ventricular contraction. The underlying rhythm is regular. The rate of the underlying rhythm is 90 beats per minute, and the P waves are present on the underlying rhythm, and the PR interval for the underlying rhythm is 0.20. The QRS is 2 boxes, 0.08 seconds. There is a ST segment elevation, so as we could see over here, if we were to look at the baseline, this is the baseline, and the ST segment is all the way up. So there's ST elevation. So the interpretation of this strip is that we have a sinus rhythm with 1 episode of PVC, and this PVC is going to be characterized by an R on T, and the reason is the PVC occurs right on the T wave. This is a very dangerous kind of a PVC. When there is a failure of supraventricular sites to initiate an impulse, then the ventricles can take over. A series of 4 beats or more with characteristics of a ventricular beat is now called a rhythm. An example of that is idioventricular rhythm. In idioventricular rhythm, the rate is going to be between 20 to 40 beats per minute because that's the inherent rate that the ventricles is able to initiate electrical impulses. If they do, then the ventricular characteristics of those beats will be noted, namely 1. A wide QRS complex and party T. If the rhythm is idioventricular, but it has a faster rate between 40 to 100, then we would call this an accelerated idioventricular rhythm. In some instances wherein the rate is less than 20, it is called an agonal rhythm or a dying heart pattern. Following is an example of an idioventricular rhythm. Rhythm is regular. As illustrated, the rate is 40. The P waves are absent. The PR interval, there's no PR interval. And the QRS is wide and bizarre. Let's measure the QRS complex. The QRS is wide. It is 3 boxes or 0.12 seconds. Since the rate is 40, then this is an idioventricular rhythm. If the rate were slower, then that would be called an agonal or dying heart pattern, or if it's faster, then it would be called an accelerated idioventricular rhythm. Here is another example. The rhythm is regular. The rate is 40 P waves. There are no P waves and therefore no PR interval. The QRS complex, they're wide and it measures 0.24 seconds. Because the rhythm is regular and the rate is 40, it is slow and there is a wide QRS complex, it fulfills the criteria for an idioventricular rhythm. Idioventricular rhythm is common following acute inferior MI. It is also frequently observed in patients who have had reperfusion therapies such as PTCA or thrombolytic administration. Idioventricular rhythm has the same identifying features as idioventricular rhythm and ventricular tachycardia because they're all wide and they have party T. The rhythms are differentiated by the heart rate. In general, idioventricular rhythm, if it's short-lived, is usually well tolerated and produces no symptoms. However, if it is sustained because of the slow heart rate, the patient would have to be treated, particularly if they demonstrate symptoms. Ventricular tachycardia is a fast rhythm and therefore has a very significant effect on cardiac output. This is a repetitive firing from a ventricular focus, which causes a fast ventricular rhythm. It would therefore carry the characteristics of ventricular beats, namely that they're wide and that there's party T. More than 3 PVCs in a row is considered to be ventricular tachycardia for as long as the rate is faster than 100 beats per minute. It is considered to be sustained if the tachycardia lasts longer than 30 seconds. Ventricular tachycardia is of 2 kinds. One is what is called monomorphic ventricular tachycardia, and the second is what is known as torsades de pointe or polymorphic ventricular tachycardia. Let's discuss monomorphic ventricular tachycardia and its characteristics. The rhythm is regular. The rate is over 100, usually up to 250 beats per minute. The P waves cannot be identified, or there's none associated with the QRS complex, and therefore there's no PR interval. And the QRS complex obviously is going to be wide and has party T. This is what's called ventricular tachycardia monomorphic. Here's an example of a monomorphic ventricular tachycardia. The rhythm is regular. Let's check on its regularity. And as you could see, it is regular. It's fairly regular. The rate is 160. P waves are absent and therefore there's no PR interval. And the QRS complex is wide. So let's illustrate how wide it is. And it looks like it is more than 3 boxes So around 0.14, 0.13 seconds. So it's wide with a RDT. The direction of the T wave is opposite the direction of the QRS complex. Notice the uniformity of the QRS complex, and therefore it suggests that this is coming from one focus in the ventricles, and therefore this is a monomorphic ventricular tachycardia. Another form of ventricular tachycardia is torsades de pointe. This comes from the French word twisting of the points. As you could see, the heights of the rhythm is varying and it has different points. Torsades de pointe is an intermediate rhythm between ventricular tachycardia and ventricular fibrillation and is very, very dangerous. It usually is associated with a prolongation of the QT interval. Prolongation of the QT interval usually associated with rhythms that are slow or bradycardic rhythms prolongs the QT interval and predisposes an individual to torsades de pointe. Torsades de pointe is caused by many factors. So to compare the two rhythms, notice now that torsades de pointe has different heights or different points, whereas in monomorphic ventricular tachycardia, it demonstrates that there is a uniformity of the QRS complexes that are seen on the monitor. Note that in torsades de pointe, as you could see, there is different heights or of different points, similar to what I'm tracing. And this reminds me of party streamers, when usually you hang a party streamer on the wall to celebrate a birthday, for example. This is the characteristic of these twisting points or of different points of this particular rhythm. So this is polymorphic ventricular tachycardia, also known as torsades de pointe. The treatment of these ventricular tachycardias are different, and that is why it's important that you know the distinction between a monomorphic ventricular tachycardia and a polymorphic ventricular tachycardia. So let's discuss the treatment of monomorphic ventricular tachycardia. Just like any other rhythm, the treatment is going to be dependent on whether or not the patient is stable or unstable. Now, for stable monomorphic ventricular tachycardia, the drug of choice is amiodarone, and this is usually administered by a bolus and followed by a drip. Synchronized cardioversion could also be scheduled for these individuals. If a patient is unstable as a result of monomorphic ventricular tachycardia, then immediate synchronized cardioversion is going to be called for. And once the patient has been converted from the ventricular tachycardia, then a maintenance infusion of amiodarone is usually started and then to be followed by oral administration of amiodarone. The treatment of polymorphic ventricular tachycardia or torsades de pointe is going to be very different from the treatment and management of a patient presenting with monomorphic ventricular tachycardia. Immediate synchronized shock is indicated in these patients. And the reason why it should be unsynchronized is because it would be impossible to synchronize the delivery of an electrical current because of the changing morphology and heights of the QRS complexes. The pharmacologic treatment of choice is magnesium. Potassium is also considered, particularly if there is evidence or if the patient has hypokalemia, which precipitated the rhythm. One thing is important to remember, amiodarone cannot be used in these individuals because amiodarone prolongs the QT interval and would not be appropriate in the management of patients with torsades de pointe. If the rhythm has been managed, then it's important to remove or correct the precipitating factors, which might include bradycardia or might be as a result of drug side effects. And we need to discontinue the drugs that prolongs the QT interval. Antiarrhythmic agents such as quinidine, procainamide, sotalol, and amiodarone may cause QT prolongation and should be discontinued. Others would include phenothiazines, as well as tricyclic antidepressants, certain antibiotics, and antihistamines could also be the culprit in initiating this particular rhythm and should be discontinued. Ventricular tachycardia, if it is sustained, is life-threatening. And the reason why it is life-threatening is because of the reduction in cardiac output and also the potential for these particular rhythms to degenerate into ventricular fibrillation or asystole. Here's an example of an ECG demonstrating torsades de pointe or polymorphic ventricular tachycardia. The rhythm is irregular, the rate is fast, P waves cannot be identified and therefore there's no PR interval. The QRS complexes are very wide, suggesting ventricular origin. And if we take a look at the heights of the QRS complexes, what do we notice? We notice a changing height or a changing points of the polarities of the QRS complex. Sometimes they're going upwards, sometimes they're going downwards, and therefore this is a classic finding in a rhythm demonstrating torsades de pointe. Ventricular fibrillation. When the ventricles no longer depolarize in an orderly fashion, it results in a very disorganized ECG rhythm. No waves are going to be identifiable. It is a chaotic, disorganized rhythm displayed in the ECG. When there's no organized depolarization of the ventricles, no cardiac output is going to be achieved, and therefore immediate death will likely result. The waveforms of a ventricular fibrillation are varying in height. There's no organization, they are chaotic, and the ECG patterns vary in size, amplitude, and shape. As you could see, coarse ventricular fibrillation have larger waves or taller waves as compared to fine ventricular fibrillation. Since fine ventricular fibrillation may resemble a systole or a flat line, it should always be verified by switching to other views or other leads to confirm whether or not this is fine ventricular fibrillation or it is a systole. Coarse ventricular fibrillation indicates a more recent onset and likely reversed by early defibrillation. Fine ventricular fibrillation waves may resemble a systole, and therefore it's imperative to confirm its presence by viewing it in another lead. Fine ventricular fibrillation usually indicates the rhythm has been present longer, and therefore it requires drug therapy and CPR before defibrillation can be effective. The most common cause of cardiac death in patients with acute myocardial infarction is ventricular fibrillation, and we need to remember that ventricular fibrillation may be preceded by significant occurrence of PVCs or ventricular tachycardia, but it may also occur spontaneously. Other causes of ventricular fibrillation include myocardial ischemia, hypoxia, electrolyte imbalance, or irritation directly to the ventricles as a result of cardiac procedures and reperfusion procedures. In a patient who has ventricular fibrillation, they are usually unresponsive, apneic, and pulseless, and death is imminent without immediate treatment. The treatment for ventricular fibrillation is immediate defibrillation, CPR, and advanced cardiac life support. Ventricular standstill or asystole is a situation wherein there is no depolarization happening in the ventricles. This either results in a straight line or there could be atrial activity, and the ECG will have manifestations of that activity like the presence of P waves. Ventricular standstill, such as a straight line, usually happens following defibrillation attempts, but it could also follow the administration of some drugs to terminate tachycardias, also in cardioversion. When cardiac standstill occurs, there is no cardiac output. The patient will not have any vital signs such as pulses as well as blood pressure. In this strip, you will see that there is no QRS at all except for P waves that are present. This represents ventricular standstill or asystole. Asystole could also be manifested by a straight line. In this strip, we have one ventricular activity and the rest is followed by a straight line. This is asystole. If this occurs, it is imperative that you have to verify the presence of asystole by switching the view to another lead. The treatment for asystole is CPR and epinephrine. This concludes the module on ventricular rhythms.